All right, we forgot one piece in our housekeeping that's really important. There will be coffee available throughout the entire conference in the lobby if anybody needs a little boost. But with that out of the way, it's my pleasure to introduce our keynote speaker. Dr. Kyle Orwig is a professor of obstetrics, gynecology, and reproductive science here at the University of Pittsburgh School of Medicine. He's also the director of the Fertility Preservation Program and the Center for Reproduction and Transplantation at Magee-Women's. Research in his lab focuses on stem cells, germ lineage development, fertility, and infertility. And their progress investigating reproductive function in fertile individuals provides a basis for understanding the mechanisms of infertility caused by disease, medical treatments, genetic defects, and aging. As a lot of people in this room know, infertility impacts 1 in 7 couples in the US and can have a devastating impact on relationships, emotional well-being, and overall health. His lab is ideally located in the Magee-Women's Research Institute and the Magee-Women's Hospital of the University of Pittsburgh and is committed to translating lab bench discoveries from the clinic for diagnosis, prevention, and treatment of infertility. On a personal note, Kyle has refused to take a lot of credit for everything he did for this meeting, but truly he has provided so much support to the entire program committee and myself in planning this meeting and getting everything off the ground. And he also really tried not to be our keynote speaker. But the program committee all agreed that we couldn't think of someone more fitting to give the updates on what he's doing given his incredible progress in the field. So thank you, Kyle.
Are the slides going to show up here? There we go. Okay. Well, thank you, Molly. It feels strange to be a keynote speaker at a meeting that you're hosting, but thank you to the program committee and Molly and Julie for the opportunity to talk about our work related to fertility preservation and fertility restoration in people with testes. So I want to start out today by acknowledging the people who really do all the work that I'm going to talk about today, starting first with our research laboratory. This is located at Magee-Women's Research Institute. And these are the people who are doing the basic research and the translational research that we hope one day will impact the clinic. At the same time, we have a clinical laboratory located across the street. This is the UPMC Magee Center for Reproduction and Transplantation. And these are the people that do all of our patient-facing work for fertility preservation. This is a research and a clinical center, so the idea here is that we develop novel technologies in the research laboratory and we translate them across the street to the clinic to improve patient care. This center is comprised of our fertility preservation program, and also we have a dedicated andrology and fertility preservation laboratory, and this is the place where we process and cryopreserve testicular tissues and ovarian tissues. And the center is conveniently located on the 5th floor of Magee-Women's Hospital, next to the Center for Fertility and Reproductive Endocrinology. That's run by Dr. Julie Rios, and that's where our IVF lab lives. And also the Men's Health Center. So a few years ago, we were able to bring all of reproductive health under one suite at Magee-Women's Hospital. Well, I'm going to start out with the basics. So spermatogenesis, the process that produces sperm, is a stem cell-based system. And the stem cell that's at the foundation of that process is called a spermatogonial stem cell, or an SSC. And this stem cell is defined like every other stem cell type that I know about, and that is by its ability to self-renew and maintain the stem cell pool, and to balance those self-renewing divisions with differentiating divisions that give rise to progenitor spermatogonia. These are diploid cells, 2 copies of every chromosome, that undergo multiple transit amplifying divisions, so one cell makes 2, then 4, then 8, and 16, etc., before finally producing a primary spermatocyte that undergoes 2 rounds of meiotic division to reduce to the haploid genome that dad will contribute at the time of fertilization. Then the process of spermiogenesis is the morphological differentiation that produces a terminally differentiated sperm with a head that carries 23 chromosomes plus X or Y from dad in humans. and has a tail so the sperm can swim through the female reproductive tract and fertilize the egg. Well, all of this process of spermatogenesis happens here inside the seminiferous tubules of the testis. So most of you will know that the testis is made up of a bunch of tubules that look like spaghetti. Sperm are made in the tubules, and then they flow out into this retestis space, and then via the efferent ducts to the head of the epididymis, where they become more mature and acquire the ability to swim. And the reason that I'm taking just a minute to show you the anatomy of the testis is because it's this structure here, the retestis, that we target when we want to infuse stem cells or other therapeutics into the testis. Now, if we take a cross-section through a seminiferous tubule, you'll see that it's a highly organized process with multiple layers of germ cells. We call that the seminiferous epithelium. The stem cells and their immediate daughters are all located down here on the basement membrane, but as those cells enter meiosis, they move away from the basement membrane and then spermiogenesis to produce sperm that are released into the center of the tubules. Well, if all of that process works correctly, then a man should produce in his ejaculate about 2 mLs of semen with a sperm count of 15 million sperm per ml. And if you multiply whatever the volume is times whatever the concentration is, the total number of sperm in the ejaculate should be 40 million. But we know it doesn't work correctly all the time. And in fact, the thing that we're here to talk about today is that there are diseases and medical treatments that can cause permanent infertility in men that can be defined as azoospermia, or no sperm, in the testis in the most severe case. And we know that some of those treatments that can cause these severe infertility problems are chemotherapy and radiation treatments for cancer, because those treatments don't distinguish between normal proliferating cells in the body and the rapidly dividing cancer cells. Those same treatments are used for myeloablative conditioning prior to bone marrow transplant for non-malignant conditions like sickle cell disease, beta thalassemia, and others. And also now we're beginning to see patients that are receiving gender-affirming treatments for gender dysphoria and are coming and asking to cryopreserve their ovarian or testicular tissues before they start puberty suppression drugs or cross-sex steroids. Well, for adult men and women, we know that we have standard of care options to preserve fertility that include cryopreserving eggs or sperm or embryos, and we know that those cells can be thawed in the future and used to achieve a pregnancy using standard of care assisted reproductive technologies. But of course, those options aren't available to all adult patients. For example, a woman who has a severe cancer diagnosis and needs to proceed immediately to treatment may not have time for the hormonal stimulation to collect eggs. And of course, those options aren't available to prepubertal boys and girls who aren't producing mature eggs or sperm yet. And we think that that's an important human health concern, because the really good news is that the 5-year survival rate for kids with cancer is now over 85%. So with improved treatments, we're producing a lot of survivors who still have their entire reproductive life in front of them. And even though these kids may not be thinking about the family that they might want to have in the future, maybe that's something that we as a research and clinical community can help them to think about. Now, as it pertains to the people with testes, although they're not producing sperm at their young age, they do have the spermatogonial stem cells in their testes that are poised to begin producing sperm when the testis matures at the time of puberty. And so for that reason, there are centers around the world that have actively been cryopreserving testicular tissue for people with testes, also ovarian tissue for people with ovaries, because we anticipate that in the future there will be new technologies that will allow us to use those tissues in reproduction. And to be honest, on the ovary side, it's, as you know, far ahead of the testis side, because we do have technologies in the clinic today for transplanting ovarian tissues. Well, we established our fertility preservation and program in Pittsburgh in 2010. It was during that year that we received regulatory approval to begin cryopreserving ovarian tissues and testicular tissues. And since that time, we've cryopreserved testicular tissues for 825 boys, primarily boys, and ovarian tissues for 410 girls or women. We're proud of the fact that these patients have traveled from all over the world to access experimental fertility preservation options that were available here in Pittsburgh. But as you can imagine, the need to travel can create a barrier in access to care. In some cases, a family may have a sick child who isn't able to travel, and of course, the cost of travel could be prohibitive. So several years ago, we established what we call a coordinated network of academic centers. Those are indicated by the marks on this map. And in this coordinated centers network, it creates an alternative for patients where they can have surgery to obtain testicular or ovarian tissue wherever they're being treated for their primary disease. And rather than the patient having to travel to Pittsburgh, it's just their tissue that travels to Pittsburgh via a special courier, where we have the infrastructure and the expertise to process and cryopreserve those tissues. We do this now both under research protocols and also as a contracted lab services. So the kind of indications that patients have when they come to us to ask for fertility preservation, and here I'm focusing on the less than 18-year-old population, are leukemias, sarcomas, CNS tumors, neuroblastomas, but you'll notice the biggest wedge of the pie is patients who are getting bone marrow transplantation for non-malignant conditions, again, like sickle cell disease, beta thalassemia, and others. Also, a growing population for us is indicated by the purple wedge of the pie, and these are patients with gender dysphoria who are getting gender-affirming treatments. And I can tell you, based on our recent experiences, that before long that will actually be the largest wedge of this pie. So when we receive tissues in our laboratory, regardless of whether it's from our local hospitals or one of our coordinated centers, the tissues are processed under sterile conditions in a biosafety cabinet. And for testicular tissues, for those who participated in the workshop over the weekend, you'll know that we cut testicular tissues into little pieces that measure between 2 and 5 millimeters across. And for ovarian tissues, of course, we start by peeling the ovarian cortex off the outside of the ovary because that's where the primordial follicles reside. And we cut those tissues into strips that measure 0.5 centimeters by 2 centimeters in size. And in both cases, we use computer-controlled slow-rate freezing to cryopreserve the tissue. And finally, for those patients who are research patients, which is the majority of them today, 75% of the tissue is stored for the patient's future use, and 25% of the tissue is donated to research so that we can use their tissues to understand the impact of their disease or their medical treatments on their gonads, and also to develop next-generation fertility treatments that we hope will be available for them in the future and allow them to use their tissues. So just to recap what I've said, the standard of care option for people with testes to preserve their future fertility is to cryopreserve a semen sample with sperm, because we know those sperm can be used in the future to achieve a pregnancy using standard technologies in the IVF lab. For patients who are not able to store a semen sample with sperm, I've told you about the option to cryopreserve intact pieces of testicular tissue. And we do that because there are a variety of technologies that are in the research pipeline that we believe will be available in the clinic in the future and allow patients to use their tissues. Maybe looking a little bit further in the future, it won't be necessary for us to think about cryopreserving sperm or cryopreserving tissue, because maybe in the future an adult survivor of a child who had cancer will be able to get a skin biopsy, and those skin cells can be turned into what we call induced pluripotent stem cells that then can be differentiated to germ cells that are either transplantable or could be differentiated all the way to eggs or sperm in a petri dish. But that's not the discussion for today. We've got a lot of work to bring that technology to the clinic. So for today, I'm going to describe two technologies that are in the research pipeline that I believe are mature and ready for the clinic. One of those technologies is a cell-based technology called spermatogonial stem cell transplantation. In this method, we transplant stem cells into the seminiferous tubules of the testis where they belong, where they can engraft and initiate spermatogenesis. The other technology is autologous testicular tissue grafting. In this case, we're not putting the tissue back in the testis, but rather we're tucking it under the skin. Scrotal skin seems like a convenient place to do that, where we expect the prepubertal tissues to mature and produce sperm. Then we'll have to go collect those tissues like you would a testis sample and tease it apart to release the sperm for fertility treatment. So starting with the stem cell transplant technique, I'm going to tell you about work that was done by Brian Herman, who is a postdoctoral fellow in the laboratory. And Brian developed what we called a monkey model of cancer survivorship. To do that, he treated rhesus macaques with alkylating chemotherapies that we knew would cause infertility. Before he did that, he took a biopsy from the testes of these animals and he cryopreserved it. In those days, we weren't cryopreserving intact pieces of tissue, we were cryopreserving cell suspensions because we were thinking about the stem cell transplant technology. After fertility was successfully preserved, then we treated the animals with chemotherapy, and every week thereafter we collected a semen sample to determine the effect of the chemotherapy on fertility of that animal. And the results of that experiment are shown here. We treated animals with 3 different doses of busulfan. It's an alkylating chemotherapy. And what you can see is that compared to the control animals, which were shown in green, all doses of busulfan caused sperm counts to go down to 0 or near to 0. Now, the animals that received the lowest dose in red, you can see that spermatogenesis eventually came back basically into the normal range. And this will be the case for about 70% of patients, that they'll be infertile for a period of time, but as long as part of their stem cell pool survives, it'll eventually regenerate spermatogenesis. Depending how much survives, spermatogenesis could come back in a year, but in some cases it comes back a decade later, so it's important to advise our patients that if they're not ready to have a pregnancy, then they should use birth control. Now, the 2 animals that were treated with the higher doses of chemotherapy, though, you can see that their sperm counts went to 0 and stayed to 0 out past a year, and we figure that represents the other 30% of patients who will be made permanently infertile as a result of their treatment, and those are the patients for whom we offer fertility preservation services. So the next question for Brian was, could we thaw out these cells and transplant them back into the same animal from which the biopsy was obtained originally? Before he did that, he treated the cells with a lentivirus that contains the green fluorescent protein. And a unique feature of a lentivirus is that it integrates its genome into the host cell genome. So when we recover sperm later, if we can do PCR and if we're able to detect that lentivirus and GFP signal, then we know that those sperm came from the frozen, thawed, and transplanted cells. So next was the question of how do we introduce those cells into the testis. Turns out that a monkey is not just a large mouse, neither is a human patient. And so the approach is different, and we borrowed on a technology that had been already developed in large animal models, and it's the technique of ultrasound-guided reedy testis injection. So you're looking at an ultrasound image of the testis here. It turns out the reedy testis is easy to visualize because it makes this echo-dense white line. And now when we infuse, we put little microbubbles in the cell suspension so you can see those microbubbles first fill the reedy testis from end to end. And now as we let this play, you can see the seminiferous tubules filling up out of the reedy testis space. So you can know unequivocally at the time that you do the injection that your cells went into the correct place and they're now lodged in the seminiferous tubules. This is a relatively simple procedure. It's not surgical. We simply insert a 25-gauge needle through the base of the scrotum until the tip of the needle comes into the correct space, and then we infuse. So here's the result for one of those animals that got transplantation of his own cells. You can see that he was producing sperm at the beginning of the experiment, but about 10 weeks after the busulfan treatment, his sperm counts went to 0. So at that time, we thawed out his cryopreserved cell suspension and transplanted it back into his testis. And about 30 weeks later, you could begin to see the sperm counts climb in the ejaculate, basically into the normal range. And we know that at least some of those sperm came from the frozen, thawed, and transplanted cells because when we did PCR for the lentivirus and GFP gene, we began to see a band show up in the ejaculate, again, at about 30 weeks. And of course, that band wasn't present prior to transplantation. I won't show you the data today for time, but we did go on to ask the question, are these sperm functionally competent to fertilize a monkey egg? We did that by sending the sperm out to our collaborators at the Oregon National Primate Research Center who performed ICSI. The number of sperm were small, so they performed ICSI, and we were able to confirm that donor-derived sperm were capable to fertilize and lead to pre-implantation embryo development up to the blastocyst stage. We did transfer blastocysts at that time, but we weren't successful to achieve a pregnancy, so that still represents work for us to do so we can show that this technique can lead to a healthy offspring. And that's ongoing work in the lab. Well, I've shown you data from the monkey, but I hope you'll agree with me that the approach for humans can be pretty similar, because here are ultrasound images of human testes, and here you can see that the reedy testis is easy to visualize in these two teenage boys, just the same way that it was in the rhesus testis. And not only are we confident that we can access and target that space accurately, we've actually done it in adult men in a pilot study who had obstructive azoospermia, and when we stick a needle in that space and flush and aspirate, we're able to retrieve sperm. And so that tells us that the needle was in the correct spot, and that was the preliminary data that was needed by our IRB committee to approve doing spermatogonial stem cell transplantation in patients. That protocol is approved now, and we're ready to proceed to do first transplants. So based on what I've said, I'm sure you understand that I think spermatogonial stem cell transplantation is a mature technology that's ready for the clinic today. The reasons for that is that this technology is actually more than 25 years old when it was originally introduced in mice by Ralph Brinster's group at the University of Pennsylvania. And it's a technique that's now been replicated in numerous mammalian species listed here, including with the birth of live-born and healthy offspring in mice and rats and goats and sheep. And hopefully we can tell you about monkeys pretty soon. The other reason why I think it's important that we bring the fertility restoration technology to the clinic is because we already have the patients. We've been promising the patients that we're going to cryopreserve tissue with you with the expectation that you'll be able to use that tissue in the future. Thanks to the work of OrwigNet, which was presented yesterday in the male section, and by a collaboration of groups around the world have reported their experience with testicular tissue freezing, we know that there are at least 3,100 patients who have cryopreserved their testicular tissues around the world, and we acknowledge that that's probably an underestimate because we only can report the places that reported to the study, and that includes the 825 patients here at Pittsburgh. Also, it's not widely known, but stem cell transplant, testicular stem cell transplant, has already happened in the human clinic. In fact, it happened a long time ago in a study that was led by Radford and colleagues, who cryopreserved testicular cell suspensions for 25 patients with Hodgkin's disease. We later learned that 7 of those patients came back to have their cells transplanted back into their own testes. This was extraordinary, actually, because at that time, the stem cell transplant technique had only ever been done in mice and rats, so jumping to human at that time was perhaps unexpected. And unfortunately, we don't know the outcome of those transplant experiments. They were never reported. However, I think the study does tell us something really important about the motivation of these men who were willing to undergo experimental and early stage technology to have at least the possibility of having a biologically related child. So finally, if we were going to do stem cell transplant in the clinic today, the question is who would be the ideal first patients and what would be the best time to do transplantation? And in our way of thinking, some of the ideal patients might be patients who are getting bone marrow transplant for non-malignant conditions, because in those cases, if the bone marrow transplant works, patients are cured of their primary disease, and there's no risk of us reintroducing malignant cells into their body. Other patients that might be good candidates are patients with solid tumors that aren't known to metastasize to the testis. Regarding the best time to transplant, we believe the best time will be during the teenage years, because it's during those years that the testis is growing, and therefore it's creating more niches for the stem cells to engraft and proliferate. So for the rest of my time, I'm going to talk about the other technology that I believe is mature and ready for the clinic, and that's the technology of autologous testicular tissue grafting. This is a study that was led by Adetunji Fayomi, who was a PhD student in the lab. He now works at the FDA. And Karen Peters, who was a research associate, and she's actually now a nurse on the cancer floor here at the Hillman Cancer Center. So again, we returned to our monkey model of cancer survivorship. We took a biopsy from the testes of these animals, but now rather than freezing a cell suspension, we froze intact pieces of testicular tissue, like I showed you on the patient processing slide earlier. After the animals were treated with chemotherapy, we thawed out the tissues and grafted them back into the same animal. Again, these grafts were under the skin, so there's no intention of restoring normal spermatogenesis in the normal place. We just want to mature the tissue to produce sperm, and then we expect to retrieve it later. Before I show you the experimental design, I want to show you the histology of the testes. So I showed you a cartoon at the beginning that showed a seminiferous tubule with multiple layers of germ cells. But when you collect a testis from a prepubertal subject, they still have seminiferous tubules. However, they contain only a small number of red VASA-positive germ cells that haven't yet migrated to the basement membrane of the tubules and haven't produced spermatogenesis or a seminiferous epithelium. Also, there are no green acrosin-positive postmeiotic haploid spermatids or sperm in those tissues. So with those immature tissues, we grafted them back into a monkey. These monkeys, as I said, had been treated with chemotherapy. I also have to admit that the animals were castrated. It's important that I acknowledge that. And this is so that we could distinguish the outcome from the grafted tissue from the endogenous testis, but also all the previous work that had been done in animal models to this date had always been done in a castrated animal. The rationale was that by castrating the animal, the gonadotropins would increase, and those high levels of gonadotropins would drive the development of the tissue. That had never been proven or formally tested, but when you're ready to embark on a very expensive monkey experiment, it seems prudent to do the things that's worked in other people's hands, and so that's what we did. Of course, we're not castrating our cancer patients. So when we went to do the transplant, we thawed out those little pieces of tissue and individually sutured 4 little pieces of tissue at each graft site to the underside of a skin flap. Those skin flaps were either under the back skin or they were under the scrotal skin. And the experimental design allowed us to compare graft outcomes in frozen and thawed tissues versus fresh, grafts that were under the back skin versus the scrotal skin. And we also injected Matrigel into some of the sites because we thought that that might stimulate angiogenesis into the tissue and promote tissue survival and development. Well, when we recovered these grafts, 10 to 12 months later, you can see that those 4 little pieces of tissue have now grown substantially and merged into one large mass. You can still see one of the sutures here in the middle of the tissue. This doesn't look exactly like a normal testicular tissue. It's a little more fibrotic than you normally would see, and in fact, it was very hard to pull it apart for those who have experience with teasing apart seminiferous tubules. But when we looked at it histologically, you can see that now the seminiferous tubules have changed quite a bit. They're larger in size. They have multiple layers of red VASA-positive germ cells with a wide open lumen in the center of the seminiferous tubule and lots of postmeiotic green spermatids and sperm. And when we teased the tissues apart, we were able to retrieve a normal-looking testicular sperm. And it wasn't just a few sperm like showing in this slide, but we were able to retrieve between thousands and millions of sperm from every single graft that was recovered. So the next question for us was, are those sperm competent to fertilize rhesus oocytes? Again, we sent sperm out to our collaborators at the Oregon National Primate Research Center. And when we fertilized by ICSI, we found indeed they could fertilize, leading to pre-implantation embryo development to the 2-cell, 4-cell, 8-cell, and et cetera, all the way up to the hatching blastocyst stage, which of course is the point when the embryo would implant in the uterus. And so that's exactly what we did. We did embryo transfer into surrogate females. A month later, we were able to confirm biochemically that we had a pregnancy from those transplanted embryos. A month after that, we looked at the fetal ultrasound and could determine that the fetus was developing normally. So at that time, we scheduled a full-term C-section, and the result was the birth of Grady. This stands for graft-derived baby. So it turns out when you make a monkey experimentally, you're obligated to name the monkey, which I didn't know until the day that Grady was born, and then they informed me. And my one true moment of inspiration, I knew immediately her name was Grady and that it stood for graft-derived baby. Grady was born on April 16th of 2018, again by C-section. The C-section wasn't medically indicated, it's just that monkeys tend to deliver during nighttime, and they wanted to make sure that Grady was delivered during the day when the staff were there to take care of both her and mom. And Grady is the first monkey baby who was born from autologously grafted, frozen and thawed, prepubertal testicular tissue, which we figure represents our prepubertal cancer patients for whom we've been cryopreserving tissues now for many years. The other thing I learned when you make a monkey experimentally is that you're responsible to take care of her for the rest of her life. And for rhesus macaques, that will be about 35 years. So I'll be writing grants for a long time. But one of the benefits of that is that we get to watch Grady's development. She still lives at the Oregon National Primate Research Center. She's shown here with her surrogate mom when she was almost a year old. And for all of us in the room, this looks like it's probably a normally functioning, healthy monkey. But what I want you to know is that there's somebody outside the glass here with a clipboard taking quantitative notes about both her emotional development and also her physical development, and I'm happy to report that Grady's development is normal, just like any animal that is born in the usual way. So to finish up, what I'd like to say is that autologous gonadal tissue and gonadal stem cell transplant technologies may be ready for the human clinic today. Indeed, we're approved to do this in the human clinic. As I said before, ovarian tissue transplantation is quite a bit ahead of testicular tissue transplantation, but I think we're ready to take testicular tissue to the clinic. But as we do that, I think it's important to acknowledge that those autologous transplant technologies won't be appropriate for all patients. Patients who have testicular cancer or ovarian cancer or leukemia may have malignant cells in their tissues, and it could be unsafe to put those tissues back inside their bodies. And patients with gender dysphoria may not want to have a tissue transplanted in their body if it required them to go through puberty in a gender that they don't identify with anymore. And so for those patients, we need to think about alternative ways to mature those tissues and produce eggs or sperm. There are several things going on in laboratories around the world, but some examples include methods to mature testicular or ovarian tissues in organ culture. Maybe one day it'll be possible to graft tissues instead of into the patient into an animal host where it can be matured to produce eggs or sperm. And as I said before, maybe one day we'll have the technology where we can take a skin biopsy from a patient and turn that into an egg or a sperm. And just to finish up with my last slide, I want to tell you a little bit about xenografting, because the exact same experiment that I told you that generated Grady, that was by grafting tissue autologously back into the same animal. We did the same experiment except grafted the tissue into a mouse host, and it turns out that the tissues matured up fine and produced sperm. You may or may not be able to see it on your slide, but when I click again, you'll see that some of those sperm are twitching, and again, we sent the sperm off to our friends in Oregon who fertilized, and this led to the birth of Crixus, which stands for cryopreserved xenotransplant baby. I had to go to the lab and ask for help with that one. It didn't come to me the same way. Crixus was born in 2019 in July, and actually both Grady and Crixus are going through or have gone through puberty now, and so we'll have the opportunity to take sperm from Crixus, he's a boy, eggs from Grady, and make a next generation of animal from gametes that were entirely from experimentally generated animals. So with that, I'll finish up. I tried to acknowledge the people who did the work as I presented it, but this work really represents 20 years of effort, and so many people contributed, both within the laboratory, but also local collaborators in Pittsburgh and collaborators all over the world. Of course, none of this would be possible without various sources of funding, and I always like to finish my talk by acknowledging patients who both inspire the work that we do and in many cases donate their tissues to research so that we can use their tissues to develop next generation technologies that we hope will be available for them in the future. So with that, I'll finish up, and I'm happy to take any questions if we have time. Yes, sir?
That's stunning. I'm wondering two questions. The monkey testis was transplanted into a mouse. I presume that was an immune-deficient mouse.
That was an immune-deficient mouse, that's right.
It's not stem cells or SSCs, it's whole blocks of tissue. Is that right?
Yes, in that experiment. So the question was, he wanted to confirm that the last experiment I showed, the intact pieces of tissue were transplanted into mice, and that this was intact blocks of tissue and not a cell suspension. And the answer to that is yes, it was intact pieces of tissue.
So that means as long as it's intact pieces of tissue, it doesn't matter if it's the xenograft is just keeping it alive with blood supply or whatever, but it's functioning as its own independent tissue.
Yeah, and I think that that's important to note too, because I think one of the important things, other people have tried to do this before, but they cut the tissues up into really small pieces, almost a slurry. And it works sometimes, but the efficiency was extremely low. And I wonder whether the larger piece of tissue actually keeps the interstitial space intact with those testosterone-producing Leydig cells. And of course, we know intratesticular testosterone is a much higher concentration than circulating testosterone, and having that intratesticular testosterone factory may be the critical thing that supports spermatogenesis.
So that means this is spectacular, that right now today you could take prepubertal boys with leukemia who had their prepubertal testes frozen in pieces, sufficiently large pieces, transplanted to a nude mouse, and you could be able to get sperm today.
That's right.
Wow. You heard it first here.
I'm sure FDA.
You heard it here first, folks.
So I'm sure FDA will have some opinions about a human therapeutic that goes through animals, but we do have animal products, either products and even cells, or at least extracellular matrix, that are used in human medicine today. So maybe the pathway to going through an animal host exists already. FDA will have to think about it a little bit. We'll help them do that.
So Kyle, I had a question. Thank you for your amazing work and leadership in this space. My question is that it seems like in the people with kids with cancer and pre-BMT, we have a fairly eloquent risk stratification algorithm that we're using to decide who should be eligible for these technologies. I am wondering your thoughts on these other populations, like how should we be approaching them? So specifically minors with gender concerns, and then also kids with sickle cell, for instance, where we know their semen parameters look pretty bad in adolescence, potentially in part due to their disease and also other disease-modifying therapies. How should we approach using these technologies in these patients?
Yeah, it's a good question. And I think that what we are all here about is to educate ourselves, but also educate our patients about these experimental technologies that we're all learning about while we're recruiting patients. And I tell patients that all the time, that we're going to learn about this together. In the circumstances that you described, let's take the simple ones. If somebody had a testicular or ovarian cancer, the advice is clearly that we're going to do a surgical procedure. It has risk, and there are relatively mature technologies out there that may allow us to put the tissues back inside a patient body, but for you that might not be safe. And so then we're going to be relying on other technologies that aren't as well developed yet, and so you're making a gamble that technologies that aren't in the clinic yet will be in the clinic when you're ready to use the tissues. And I think it's important to give families that entire background of information so that they can make an informed decision about whether they want to store the tissues. And I'll just make one other comment related to that. You mentioned sickle cell, so I'll comment on sickle cell. And we know sickle cell patients get multiple blood transfusions that can be gonadotoxic. They also get hydroxyurea that can be gonadotoxic. I don't think we know very well whether those things are reversible or not reversible. We don't know the extent of damage. That's an example of something that we're learning alongside of the patients. So as patients decide to participate in research, each of them are donating a portion of tissue to research so we can actually look at patients who had hydroxyurea versus ones that didn't, ones that had multiple blood transfusions versus ones that didn't. So as we continue to accumulate patients, we'll get numbers of patients in each of these categories and begin to answer some of those questions, and hopefully that will improve our counseling.
Hi, Alexa Walsh from Phoenix Children's. I'm just curious, how long does it take to mature the testicular tissue in the monkeys?
Yeah.
And then how long do you think it'll take in the patient population as well? It's a question we're getting.
Yeah, so that's a good question. And again, regarding the human patient, we will learn along with the human patient. I have to tell you, with the monkey, this was a big question for us because we had transplanted the tissues, and about 8 months later, we started wondering, is it time for us to collect the tissues yet? We don't want to collect it too early because maybe sperm didn't happen yet, but we didn't want to collect too late because who knows, maybe the tissue develops and then it actually undergoes necrosis. So it was a gamble. It turns out when we collected tissues from an 8 months after transplant, we could retrieve sperm, and we had, I think, 5 or 6 animals on that study that we collected all the way through till 12 months. So at least we know between 8 and 12 months. The process of spermatogenesis takes a little bit longer in human. It's about 55 days compared to 72, so I think it's reasonable to expect that a slightly longer time might be needed for human tissues. Maybe it'll be a year to 18 months or something like that. But again, this is something that we're going to learn along with patients. And it might not work, by the way. That's the other thing we're going to learn with patients. Yeah, Kenny?
So you've demonstrated with the whole tissue pieces what could be a Nobel Prize winning experiment in patients. But on the other hand, with the SSC suspensions from the prepubertal boys, can you, well, this is the question, are you ready today to inject those into the reedy testes and have another blazing success? And just one step further, what about the PGCs that we're all making? Do you think if they were injected into these early pubertal boys that they might convert into spermatogenic stem cells?
Yeah, so that's a lot to unpack. First of all, I'll tell you, I have to admit something, and that is that the first 7 patients for whom we cryopreserved cell suspensions, not tissue pieces. So for those patients, we will have only the option to do cell suspension. In fact, we're just about ready to do our first transplant. It's one of those first 7 patients, and so the first transplant attempt will be a stem cell transplantation and not a tissue grafting. The second part of your, so if you take a skin and you turn it into a primordial germ cell-like cell, again, I can't tell you about human because we're not there yet, but in mice, those cells can be transplanted, become spermatogonia, and start spermatogenesis, but they aren't nearly as efficient as the spermatogonial stem cell itself, and so we're just seeing technologies come out now where we may be able to differentiate further in a petri dish and get a bona fide spermatogonial stem cell that I suspect will have higher transplant potential.
We have time for 2 more questions.
Thank you. Do you hear me? No? Yes.
There you go.
Congratulations for this fantastic translational research. I have just a question, but I think Dr. Silver also asked a bit about this. You have presented 2 methods, one with cell suspension and then injection in the ready testes, and also the cryopreservation of tissue. And could you tell us a little bit what are the advantages and disadvantages of those 2? What do you think is the best?
Of the 2 freezing situations or the 2 restoration?
Well, if you freeze the cells, so you have to inject the cells, or if you freeze the tissue, you have to transplant the tissue somehow. On the freezing side, of course, if we freeze intact pieces of tissue, it preserves the option either to do a tissue-based therapy or a cell-based therapy, and that's why we do that, starting with patient number 8. We've done that continuously since then. And one of the things that I'll tell you, what justified us doing that, is that I naively thought that freezing a suspension of cells would be better for the cells than an intact piece of tissue where you can imagine the outside of the tissue is exposed to different cryopreservation conditions than the center. Turns out I was wrong. So in those early days, I did an experiment where we thawed tissue and then froze thawed tissue and made a cell suspension, and the recovery of transplantable stem cells was higher from the frozen tissue than it was from the cell suspension. So there was absolutely no advantage to freezing a cell suspension, and we went immediately to freezing tissues. On the backside for fertility restoration, the advantage of the tissue is that we expect that we can recover that tissue 12 to 18 months later and tease it apart, and we'll know immediately that we had sperm. I think that's good for the patient because we can tell them we have sperm when you're ready, and it's good for the field because now we can demonstrate that this method of freezing and thawing tissue works, and we can get a fertile outcome. Thank you.
But it can't restore normal spermatogenesis. That's in the testes. That's the downside.
Hi, Kyle. I think fabulous work, and congrats to all of your team. I'm interested in the legal situation here in the US for you to actually use xenografting to develop human gametes and use those for patient treatment.
Yeah, so the answer is that I don't know. We haven't even tested it. In fact, I haven't even published that result yet. So all we can say now is that the approach is feasible, but if we thought that that was a real path to the clinic, it's going to require some discussions with FDA and figure out, maybe it's a non-starter, I don't know. So for us, this was just a fun science experiment to show us what's possible. Or maybe they'll tell us what the path is and we'll start doing the appropriate experiments to check the boxes for FDA that hopefully would ultimately lead to approval.
Brilliant.
Thanks, everyone.